This audio clip only, no video, so you don't see me this week. But the audio clip covers both the objectives for the week as well as the lecture. And so let me just quickly go over the learning objectives. At the end of this lecture, you should have a really firm grasp on population health and what it is, what are the opportunities associated with it, and what are the challenges. There'll be some terms that will be important for you to remember and understand: value-based purchasing, meaningful use, the electronic health record, MedPAC, patient experience, what it is, and pay for performance. We'll also look at some of the trends in inpatient and outpatient care. And then I want to be sure that you understand what demographic is responsible for the majority of health spending in this country. And then finally, we'll look at some of the measures that organizations have put in place to help reduce costs and and improve overall quality. So, of course, your assignments first is to review this lecture and listen to it in its entirety. And there's a research article. It's not even a research publication, but it was published in the Journal of the American Medical Association. And I believe Harold Sox, SOX, is the author, and it speaks to population health and health care and the intersection between the two. And then there's a video clip that you'll need to take a look at that was produced by healthcare analysts, and it's on financial models. So let's go ahead and get into the lecture for week 8, population health and care coordination. I'm going to, it says population health and care coordination, but I want you to see them as two distinct topics for this particular week, even though there's some convergence between the two. I probably should have one lecture on population health and a separate lecture on care coordination. So just keep that in mind. All right. So anyone in healthcare knows that population health is like the buzz term. It is, I'm telling you, what people are talking about across the nation. What is it? How do we address it? and well, what does it mean? So when we talk about population health, the Institute of Medicine defines it as the outcomes of a group of individuals, including the distribution of such outcomes within the group. And you can segment the population depending on your organization's mission. You may be more focused on a health condition, for example, cancer or asthma or heart disease. You may also segment your population based on a geography, a defined geography. You can also segment your population based on demographics: African American, Hispanic, seniors, persons with disabilities are different examples. But what's important for us to acknowledge as we talk about population health are the public health sector's perspective and the healthcare sector's perspective. And so, from a healthcare provider perspective, the perception of population health is really the population that I'm taking care of. So if you have 100 patients with asthma, a panel of 100 patients with asthma, that's the population that you're looking at. And the goal is to demonstrate improvement of health outcomes of that population over a period of time. However, the public health perspective is not only the care that's provided within the walls of the health provider, but also the community in which those asthma patients live. And so, how do you integrate the two in taking care of the patient? And so that's been the struggle. And the challenge has been, or the issue is that our healthcare system, the infrastructure for doing that is not in place. And that needs to happen. And there also needs to be incentives around how to do this. Right now, the incentive and the traditional incentive has been around just keep taking care of sick people. But we have to think differently about how we provide care. And that's why it's such an exciting time. And that's why it's good that you are in a school of public health and your focus is on health services administration. People always ask me, well, is it important to get a degree in health services administration? that's within the confounds of a school of public health, and I can't say how important that is because that's the way the nation is going. I know that some universities have programs, health services programs, and they're just independent programs, and those universities aren't affiliated with a healthcare system or a school of public health. And I just don't think those students get the same experience. And so, good for you for being enrolled in this program because this work is not just around um, the health care that we provide, but it's also around practice and policies that are necessary to improve the health of the nation. So take a look at this slide here. Place matters. We know that zip code can be a better predictor of health status than genetic code. And so this visual here displays the District of Columbia and the outskirts of the District of Columbia where you see the lifespan is longer. And these communities outside of the District of Columbia, the quality of life in these communities is much better than what you see here within the city. And so we know that because of a person's community, there can be a correlation between the state of the community and health status. And so, how are we incorporating that in health outcomes? And so, that's prevention. If we're doing more to address some of the upstream factors in these communities, the social conditions of which in which many of these folks may live that contribute to poor health, I mean, we have to address that. And it's markedly clear. I mean, it's clear when you drive and go out into these communities, the quality of life is just so much different. And so, as health services um, planners, it's important for us to consider that because that is the direction that the nation is going in. We're finally starting to focus on prevention with a public health perspective versus just putting a lot of money into healthcare and treating the sick. I like this slide because it illustrates that the totality of a person's health and well-being is much more than just clinical care. And as health services organizations, we're good at this. We're good at the 20% piece in providing the clinical care and making sure people have high quality health services. That's our mission, right? But what about the social and economic factors and the physical environment and the roles that they play in achieving health outcomes? And so many of our resources have been pumped into this space here and less here, and that has been a problem for the country, for the nation, and especially for certain types of communities. And so it's important to realize this and acknowledge this and have a much more comprehensive perspective in how we think about health outcomes and health status. It's not just about the healthcare system. Even physicians will tell you the same thing. The Robert Wood Johnson just released a publication, and this stuck out for me because, and I wanted to include this slide in my lecture this week because it shows that physicians even state addressing a patient's social needs is just as important as dealing with their medical conditions. And I know physicians that have literally been burned out because they're spinning their wheels, they're working and they're providing the same care, and people are coming back for the same conditions. And the question is, why are they coming back for conditions that can be prevented? And a lot of it has to do with their surroundings. When they leave the healthcare organization or the primary care practice and they go home, they're living in communities that just aren't structured for health and well-being. And so they are frustrated, many of these physicians, and many have left the field and now they're working on policy development and they have more of a focus on public health. But what's important here is that addressing the social needs is really important, but we just don't have the infrastructure in this country to do that and do it well. And that is where you come in because we need leaders of the future who appreciate this connection and are willing to help us change the medical model to integrate the social component. Now, one organization that I want to share with you, it's called Health Leads, and the Robert Wood Johnson Foundation has provided a lot of financial support to Health Leads. Health Leads is an organization that targets med students, folks who are getting their master's in public health, community health, health education, and they are literally putting these individuals on site in primary care practices, targeting primary care providers that deal with or have large patient populations of individuals who come from low income or underserved communities, or they're just dealing with a lot of social issues. And so these students are literally helping these patients. So they see their doctor, the doctor says, I'm going to provide a prescription for you. And the prescription is not just medication, but it's a prescription for food. You need to go see a Health Leads representative and they will help you. Well, what the physician is saying is, or what the physician has learned during the assessment process, is that the patient is going to be provided medication, but the patient doesn't have food, and the food needs to be taken on a full stomach. I mean, the medication needs to be taken on a full stomach, but the patient doesn't have access to food. And so a prescription is written, and the Health Leads representative helps the patient access food. And so that's an example of what I mean. Excuse me, I have a cold. That's an example of what I mean around integrating the social factors in the traditional medical environment. Now, that's really a band-aid. There's a bigger issue there. The bigger issue is why does the patient not have access to food in the first place? That's a bigger issue, and we need to work on that too. But there's always going to be a need for safety net services, and this is a perfect example of how you can achieve that. So a more comprehensive perspective is provided here for you. You can see the upstream forces, and then if we start to acknowledge these factors and the role that they play in health and well-being, we'll be much better off. And then down here you'll see the life course process, and depending on where the individual falls on the spectrum will determine the types of services they need for health and well-being. And then you'll see here the society and individual, and it's important just for us to understand the connection between individual health status and society. We also must recognize that there are disparities based on certain populations. There are health disparities or health outcome differences in health outcomes based on race, ethnicity, gender, socioeconomic status, and geography. And so as a healthcare provider, number 6 up here, it's important for us, or as health services leaders and planners, it's important for us to recognize all of these and the complexity that's associated with all of these factors and how they contribute to health outcomes. And it's important for us to establish interventions that take all this into consideration. There's a lot going on nationally to help build this bridge between the healthcare system and public health. We know about accountable care organizations, community transformation grants. This is funding that's being allocated for communities that have demonstrated the capacity to build this bridge and improve the health outcomes of a specific geography. There's also public health workforce expansion grants that are now available, and there's going to be more funding coming down the pike in this area. Health navigators are playing an important role in making this happen. Health navigators are sometimes they're lay people, sometimes they're nurses. It just depends. There's a lot of different types of health navigators, and that's one area that I know Georgetown University is working on. How do we really develop the health navigator into a truly bona fide health profession? There's also projects around demonstration. There's demonstration grants. A demonstration project is, you have a really good idea and you want to test it, and so funding is provided, and the goal is that because of your idea you'll see some improvement in health outcomes, and the goal is it'll be an evidence-based practice, and the goal is to take it to scale. And then there's research funding coming down the pike. The PCORI is what stands out most in my mind right now. PCORI is, I think it stands for Patient-Centered Outcomes Research Institute, I believe, and that organization is responsible for the millions of dollars that have been appropriated by the federal government to conduct research on best practices using the consumer as the primary driver for how the work is done, or how we actually reform how care is provided. And then there's a need to restructure the medical education curriculum. The traditional medical model does not incorporate the social components and how you treat patients. And so I'm working with some of the folks at Georgetown who are responsible for training med students. And the goal is for them to rotate through some of our community-based programs, so that these future nurses and physicians can really have a better understanding and appreciation for how community impacts overall health status. So as I wrap up this segment, I want you to think about these 3 questions. You don't have to submit anything to me. It's just, these are questions that you should be able to have, you should be able to have a informed conversation with someone around these areas. For example, within this context, what are some of the key considerations for health services planners? And we'd be remiss not to think about technology and the role that technology can play in helping us build that bridge between the 2 sectors. And then improved health status obviously is the vision and the outcome, but what types of indicators or measures can be analyzed to evaluate movement in this direction, specifically when we're looking at the social determinants? So that's it for the population health piece. I'm going to stop with that, and we're going to change channels. This was a separate week, okay? There's some similarity and some convergence between this next part of your lecture and what we just discussed, but I want you to, in your mind, just think of this as a separate lecture. All right, so quality, care coordination, and future directions. If you do not have this document or this book, you need to get it. You know, in mid-2000, there were several landmark reports that were produced or released by the Institute of Medicine, and Crossing the Quality Chasm was one of them. And this book really, or this research, or this piece really did a great job helping us understand that quality of care is going to be contingent upon us having a systems-based approach to how we organize ourselves as health service providers. Quality problems are typically are not because of failure of goodwill, knowledge, effort, or resources devoted to care, but because of the fundamental shortcomings in the way care is provided. Care is fragmented, and we're working in silos, and there's lots of duplication of services, and all of that can result in some craziness and some medical errors and some safety issues. So I encourage you to get the book, read it before you graduate, please. So this is the mental model for crossing the quality chasm, and you'll see outside of the square, consumer participation. Again, this is really, really important for us as health services planners to think about the consumer and the role that the consumer can play in our planning efforts. There must be leadership that understands this and can help operationalize these approaches you see here. Everything must be integrated, all these factors. There must be integration, and we can't work in silos. And there must be this clinical perspective in all of these areas. So let's take them one by one. So standardized practice elements. Clinical assessment. This is a perfect example of what I was talking about with the asthma patient in the slides earlier. The clinical assessment can be rethought to consider the home environment. So when you're assessing the patient for asthma and the issues that they're dealing with, are you also assessing or asking questions to get to their home environment? For example, do they have roaches? I know that's it's kind of random, but that's a common issue. That's a common cause for asthma flare-ups. And so if there's roaches in the home and you're not doing anything about it or helping do something about it, you're just going to keep seeing that patient. And that's not the direction we want to go in this country. Again, an opportunity for the healthcare system to collaborate with public health. There must be interventions and there must be IT infrastructure. Um, IT is a really, really big deal. It's very complicated, but I'm telling you, when it's done right and when it's done well, you decrease risk for error, duplication of services. You become much more efficient, and care is improved. We must have guidelines, and those guidelines must be based on what the evidence has told us. And we need people in leadership who understand evaluation and how to take a promising practice and convert it to an evidence-based practice. Measure performance. The 6P areas that aren't broken out here, I will share them with you. Care must be effective. That's the first one. Care must be safe. Care must be patient-centered. Care must be timely. Care must be efficient. And care must be equitable. Those are the 6 P's that are found in crossing the quality chasm. Please be sure you know those. Effective, safe, patient-centered, timely, efficient, and equitable. And also, to improve performance, we must be a learning organization. And we must embrace learning, and we must have a continuous quality improvement mindset. And we must reward ourselves internally, and we must be rewarded externally for our work and the contributions we're making and how we're advancing the field. And then finally, the evidence. Evaluating effective strategies and translating from bench to bedside to community. I mean, this is the mental framework. This is the takeaway from crossing the quality chasm. And I just wanted to share that with you. And I want you to think about, as planners, how do you keep all this into consideration in your work? I go to lots of conferences and meetings, and I've even sat in on workshops on quality. And I found myself listening to all these experts in the field, and at the end of the day, I leave, I'm like, I can't believe we just spent a whole day talking about quality. It's basically these 4 pieces. Was the care safe? Did you achieve the outcomes that you were looking for? Were your consumers happy with the care? And was it provided at the lowest cost? If I'm a consumer, I want to be sure that the care that you provided was safe, the outcome was achieved, it was done in a way that I evaluated as, satisfactory or beyond satisfaction, and it was done at the lowest cost. Simply put, that's quality. But we can sometimes get so overwhelmed and make things so complex, and we end up going down going in this direction, and you're just like, I have a headache. It's very simple. This is quality. So now I'm going to move on to the next piece here. I'm going to introduce you to the video clip that you need to watch, because the Centers for Medicare and Medicaid Services are doing a lot in this realm, and they pretty much set the standard for the nation, and payers and providers follow suit. And so after watching this video, you should be able to define and articulate value-based purchasing, meaningful use, the electronic health record, MedPAC. What is MedPAC? The patient experience and what that means and all it encompasses, and pay for performance. And so you can either click on the link below, or you can just select the hyperlink to access that clip, that video clip.